Okay. Our next speaker, Barry, laparoscopic single-site helomyotomy and anterior fundoplication for achalasia. Please, Linda. Just come here. Yep.
The green arrow goes forward.
Okay. Thank you. Good afternoon. I'd like to thank SAGES for the opportunity to present here. I'm Linda Barry, and I'm an MIS fellow at University of South Florida. We know that achalasia is a dysmotility disorder of the esophagus, and the treatment is mainly palliative in nature. It's either endoscopic or surgery is another option, with laparoscopic helomyotomy with anterior fundoplication as a standard first line of surgical treatment. Now we're applying less surgery to the surgical management of achalasia. It's the marked evolution of videoscopic approach from a thoracoscopic to laparoscopic with anterior fundoplication. And now we're utilizing less techniques so that we're able to do a less helomyotomy with anterior fundoplication in a setting of scarless surgery. And this is what we're looking for, a single incision which will heal with an unapparent scar. So the purpose of our study is to evaluate with a large series of patients our initial experience with less helomyotomy with anterior fundoplication for achalasia. We had hypothesized that less helomyotomy with anterior fundoplication can be applied to achalasia with the same efficacy and safety profile as conventional laparoscopy, with superior cosmetic outcomes. So here, we note that when you look at the conventional laparoscopic approach versus the less approach, there's no difference in gender, age, BMI, blood loss, endoscopic preoperative treatment, or length of stay. And there were no conversions to open procedure in either approach. The one notable aspect is that there was a longer duration in time of the operation amongst the less Heller patients compared to the laparoscopic approach. Here on this slide, it's a bit busy, but the key thing to note are that the intraoperative events are the known events to occur in helomyotomy, no matter what type of approach. They were small in number, and they were addressed intraoperatively. The postoperative complications were noted to be either related to the underlying comorbidities of the patient, but not specifically related to the myotomy itself. There were no perioperative mortalities in either group, and in specific reference to the last group, 1 to 2 ports were added in approximately 11 patients in the setting of extensive adhesions, a large hiatal hernia, or an excessive amount of intraperitoneal fat. Here, the most notable thing to see on this slide is that before the myotomy, when you look at the conventional approach versus less, they're similar in the degree of frequency of symptoms, in addition to the severity and how significant the amount of severity of symptoms. When we looked at patients and we asked them in terms of symptom resolution, we noted that approximately 82% of patients who underwent laparoscopic approach had excellent or good symptom resolutions versus the less Heller approach, where it was 88% of the patients. When we assessed patient satisfaction, we had 90% among the laparoscopic group versus 94% in terms of patient satisfaction. So what we can say is that less helomyotomy compared to conventional laparoscopy can be done safely with a shorter hospital stay, with no adverse outcomes. Postoperative complications were related to underlying comorbidities. There was a significant reduction of symptoms and durable outcome, and there was a very high patient satisfaction. So therefore, yes, there was a longer operative time, but it did not adversely affect outcomes. And one may actually ask, is there less pain, quicker return to daily functional activity when you're in the setting of a single scar? But one thing we do know is that there's superior cosmetic outcomes for which our patients are very grateful. I'd like to thank SAGES for the opportunity to present. I am Linda Barry from USF. Thank you.
Thank you very much, Linda.